Folks, thanks for joining us. We're almost ready to get started. Just giving a minute here to let people log in, and we'll be with you in a few seconds. All righty. Thank you, everyone. Thank you for joining us. I am here. My name is Matt Kinch. I am the general manager of MedLife, and we are super excited to have everyone with us today for our very first ever roundtable. We are on Zoom and we are streaming live on YouTube. If anyone was unable to get into this call tonight, please just refer to the MedLife YouTube channel and you'll be able to follow us live and ask your questions there. I would like to get started by welcoming our guests. Starting first, we have Dr. Nick Ellis. Nick is the founder of MedLife and currently splits his time between being an emergency room doctor in rural Texas and running MedLife, the nonprofit organization, bringing you this live roundtable here tonight. He spent the last few months of Peru in lockdown in Lima and returned to Texas when it became a hotspot for COVID-19. Welcome, Nick. Are you there?
Hey, everybody. I'm here.
All right. Welcome. I'd also like to welcome Dr. Alexandra Nunez Garbin. During COVID, she was working as an NYC as a resident physician. She finished her residency in internal medicine in June and currently works as a hospitalist. She now works at Great Plains Health Hospital in North Platte, Nebraska. She worked as an ambulance doctor in a clinic as a general physician and as a university professor, and also on MedLife mobile clinics after her graduation. Welcome, Dr. Nunez. Are you there with us?
Thank you. Yeah. Hi, everybody.
Welcome, welcome. And finally, we have Elizabeth Shank, nurse practitioner, who has currently and is currently working in NYC and has been during the height of COVID. She used to work as a MedLife intern and associate of student affairs and is currently at Mount Sinai Hospital in the surgical and transplant ICU. Welcome, Elizabeth. Are you there?
Yep, great to be here.
Loud and clear. Great. Welcome, everybody. We're super happy to have everyone here. For our listeners, I'd just like to welcome you once more. We're going to go through a number of the questions that were submitted to us previously, but you'll also be able to ask questions both in our Zoom room here now and via YouTube. So anyone, once again, that isn't able to get into the Zoom, if you have friends asking, you can recommend that they check us out on our YouTube channel. But to kick things off, I'd like to really start by giving everyone a question of kind of in their professional roles. We'll start with Dr. Ellis. How has COVID affected you in your work in the ER?
Hey, everybody. So as you know, it's a super complicated question. There's a lot of aspects of COVID that have affected things. For me, I'm sort of a travel doctor, not sort of, I am a travel doctor. Over the last 4 years, I've been living in Peru, and then once a month I'll fly up and work my shifts in Texas. And so right away, the immediate issue for me was flights went down. And so I was stuck in Peru and couldn't work for a couple months. Eventually my family was able to get on an embassy flight back to the United States, and I was able to start working again. And even now there's a lot of, when I first started flying and doing my shifts, the airlines would ask you, have you had contact with anybody that had COVID? Because if you have, you're not allowed to fly. And so I'd kind of stand there and be like, oh, sort of, right? Like, you don't know what to say, but they've sort of advanced and figured it out now. And so now they say, if you're a healthcare worker and you've, worn PPE according to what the CDC recommends, like, that's okay. And so, like, I guess that just goes to show you, like, as this thing has evolved, it's been very complicated. And so everything for me getting to work, I have a family. And so after work now, usually on the 11th, I would fly home and be with my family. I'm doing a 4 or 5 day quarantine followed by a COVID test. So I'm kind of doing, a mini quarantine when I get out of work. And then just in work too, it's very complicated, right? I mean, putting on PPE, taking off PPE. Probably my reality is a little bit different than Elizabeth and Alexandra, in that in the ER you don't always know if someone has COVID. You know, there's a lot of stories in ER where somebody comes in for a fractured bone or something, and they routinely do COVID tests, and it turns out somebody was COVID. So it's really complicated in terms of, you know, if someone comes in very clearly COVID, you can figure it out, but there's a lot of folks that have it and you don't know. And so you think you're just treating X, Y, or Z, and it turns out they have COVID in addition to that. And so makes it pretty challenging in that sense.
And same question, Dr. Nunez, or can I call you Alexandra? If you could just share a little bit of how COVID affected you in your role.
So when I was working as a resident, it was about May or April when I started the peak of COVID. So initially, there were not like few cases in the hospital. We were planning to open more ICUs, and then immediately it started like picking up very fast. A lot of my co-workers, like my co-residents, like fell sick with COVID. So they would call us to cover them, even though we were not sick call, they would call us because there were so many patients in the hospital that we would just have to go to the hospital. And sometimes we wouldn't have a day off because we needed to go and help as much as we could. So it was kind of like we were feeling overwhelmed and like sometimes burned out, and see how patients would end up very sick. Like they would come just with respiratory failure, like breathing normally, or just a little bit of shortness of breath. And then the next day they would be connected to a ventilator. So it was emotionally challenging as well. So that was kind of my experience when I was a resident at that time. I didn't have a problem with traveling because I was living in New York City at that time. And I was just few minutes from the hospital, just walking. So that was really an advantage to just be close by. So yeah, I learned a lot of things on the way. And at that time, we didn't know what was going on. So it was a little bit stressful as well, seeing how sick the patients were. And we didn't have like a guideline or an algorithm to follow. So we would just do our best and hope for the best as well. So not all the times we were lucky, but when we were very happy that the patient would be.
Okay. And Elizabeth, on the front lines, can you talk a little bit about experiencing COVID in New York?
Sure. So I was in the ICU. I am in the ICU. And when COVID hit and was at its peak, it really took over the entire hospital. We set up makeshift rooms in the atrium. There were tents out in Central Park that were affiliated with Mount Sinai. All of our ICUs turned into COVID ICUs very quickly. All of our post-transplant patients had to be moved to the PACU and like a ICU, which really, they didn't even have the equipment for the appropriate monitoring of the very, very sick, immunocompromised patients. But they had to keep them away from all the other COVID cases, which was just like a wave. We were doubled up. We never got to the point where we had to share ventilators between patients, but we did have ventilators that our staff wasn't familiar with how to work. So we had respiratory therapists that came in and sort of guided us, but they were stretched very thin. It was all very chaotic, but the sense of camaraderie among the staff was amazing. I mean, we were all sort of working on the fly because the protocols kept changing as well. So there would be one treatment modality that would be used, and then they would quickly shift to saying, okay, no, we're going to do just 3 days of this medication. And then, oh no, now we're just going to do one. And now the protocols, you have to be, qualify in this sense. Or it was very, think on the fly and go with the flow, because these patients were so sick and so labile that we were all just sort of in a state of shock. And then things went back to normal, and now things are sort of starting to pick up a little bit again. But I think everybody learned a lot from the COVID wave when it hit its peak, in how to deal with grief, especially in being the only connection that the patients had with their families, or rather that the families had with their patients, because there were no visitors. Everything was virtual. I was using Zoom just to do a video call for patients to say goodbye to their family members in the ICU who were going to be made DNR, DNI. So it was really heavy. But like I said, the camaraderie of the staff was really amazing.
Wow.
Can you explain what DNR, DNI is for everybody?
Sure. Sorry. So DNR, DNI is do not resuscitate, do not intubate. I've seen most of these cases, these patients were already intubated on the ventilator. So when a patient is made DNR, it means do not resuscitate. They don't want certain life-saving measures to be taken should their heart stop.
And kind of putting the question to all of you, because all of you very much were watching the news and getting these kind of updates as they were coming. Things happening in Asia and then Europe and systems collapsing. Nick, can you speak a little bit to kind of your emotional state, knowing that you're going to have to potentially put yourself in harm's way to do your job, thinking about how you protect yourself, those kind of things that, we typically don't think about when we think of our health staff, but you actually have to go in and put yourself in harm's way.
Yeah, I mean, it's tough. I would say early on, it was a little bit terrifying in some ways, like there was just so much that was unknown about it. It seemed like early on that young people weren't really affected all that much. So you sort of felt like you have that on your side a little bit. However, once in a while, there would be a case in the news of somebody very young, physicians dying. So there's certainly a heightened level of stress. And I would say, I think that the way that I would describe it is kind of when you're, if you have sort of a flight or fight reflex where you're just sort of at a higher level of alertness all the time, and, being aware of touching your face or doing this or, that always exists in medicine. I mean, there's always times when you have to really be at sort of your top and functioning at a very high level. I would say, though, this has been long stretches of that, so where you might be expected to sort of be at that level of alertness or high functioning for hours or a couple of days or something, now it's just kind of perpetual, and so there's certainly a lot of kind of exhaustion that comes with that. And I think, for me, I have a little boy, my wife, there's certainly complications there. Childcare is a little bit difficult. I have older parents that have volunteered to help with childcare while I'm gone, but we're really reluctant to involve my parents just because they're in their 70s and 80s, and to get them involved really is concerning, or the idea that you might bring COVID home to your family. And so I think it's a heightened level of sort of alertness, stress, kind of anxiety that goes along with it. But I think, Elizabeth sort of said, there's also a sense of camaraderie. And so I think as time goes on, people kind of figure this out. You start to gain a new sense of normalcy, which is a little bit dangerous too when you're dealing with the pandemic, kind of normalizing it too much. But that's what I would say. I mean, there's certainly challenges to it, especially early on when so much was unknown. Things like, you saw in the news, what kind of mask do you wear? Do you need to wear a mask all the time? And there was just so much misinformation. And, even PPE was a huge struggle early on. And so I ended up buying a lot of PPE for myself. And I think it's a challenging time in that sense.
And Alexandra, being in New York City at the height of all of this, and kind of to the same point of what Nick mentioned, this kind of increased exposure and some of the things that we were hearing about how people on the front lines were being affected just by extended exposure. Tell us a little bit of your mindset going into that each day.
So initially, we didn't have enough PPE. We would just use the face masks, the regular ones, even though when we were going into a patient's room that they were going to be intubated. And then suddenly we like ran out of like N95 masks. We have to just reuse them for a week or try to use it as long as we can and put on top of that like a face mask to protect that. But then little by little, the program or the hospital tried to get more PPE. So they were very helpful and supportive in terms of that. They wanted the best of us. They wanted us to be protected in order to also be able to help the patients and be able to be functional at the hospital. So that was really helpful in terms of that.
And Elizabeth, how did you get yourself into the mindset each day as you had to go in, knowing that, you know, New York is a hot spot and you are some of the first people that are coming in contact? How did you prepare yourself?
Fortunately, our hospital was pretty well prepared in terms of PPE. We did get to the point where the nurses and all the medical staff had to reuse one N95. I think for about a week. We were supposed to keep it in a brown bag and keep our face shield, and then only recycle it every week or so. And at one point we almost ran out of gowns. I remember waiting for a supply truck to come to be able to restock the gowns. So we were sort of hesitant to go into patients' rooms at the time. But for me personally, I mean, I'm fortunate that I don't have like a family that I live with that I have to worry about. I just come home to my cats. So that wasn't a stress that I had to deal with. I felt really bad I had quite a few coworkers that had families and whatnot, and they had to stay in hotels. Fortunately, here in New York with the height, there were a lot of companies, hotels and places that offered free housing for healthcare workers that were working in the hospital and needed to quarantine away from family. So there were opportunities in that sense, but working on the floor and in the ICU when COVID was at its peak, we were doubled up and it was chaotic and crazy, and PPE was going really quickly in the beginning when we were using them as they should be used, which is after each patient encounter, you have a new mask and a new gown and new everything. One time I was walking by a patient's room and the patient was waking up, intubated, was waking up and was going for the tube to self-extubate, which is a big, it's a big to do. It's a big problem because they can cause trauma to their trachea. There can be, you might have to re-intubate them. So it's sort of always a big, like everybody jumps to the bedside. And in this case, I jumped to go open the door and my colleague said, "What are you doing?" No. So we were, banging on the window, of the glass of the door to say like, stop. Realizing like, wow, this is really affecting patient care, but you have to think of yourself and your own safety first and the safety of the people you go home to. So it was very, very complicated. But fortunately, my hospital had pretty decent PPE.
Fantastic. Just a disclaimer for everyone watching, we welcome any questions and comments as we're going through here. If you'd like us to ask any of our guests any questions as we're going, we have a list that you've sent us previously, but once again, we welcome any questions as we're going through this. Turning a little bit, all three of you have a connection to Peru and how MedLife works in communities in Latin America, as well as experience in working in North America. And so I'd like to start by asking you, Alexandra, just a little bit of what do you see as some of the similarities in how Peru and the United States has responded, and kind of have you noticed anything that's jumped out at you as being a good decision on either the US or Peru's part in their reaction to COVID as it came along?
I think similarities are that I think both are trying to get prepared. And I know it's completely different in terms of how prepared the America is, the US or Peru. I know in Peru we have a lot of deficiencies in our health system. where I experienced like firsthand with my mom when they wanted to take her to the ICU. She was no COVID, but they couldn't like find a bed for her, and they were like trying to call different hospitals, and there was none for like hours in order for her to go to the ICU. So it was very stressful at that time. And I know here we don't have that problem in terms of finding an ICU, and probably depends in which state. But personally, when it was in New York City, I know there was some problems, but we tried to open more ICUs, and we had that facility to do it, which in Peru we don't have even the resources to do it. So I think both try to do their best, but in terms of how successful they are, it's completely different. And and also I think that in Peru they took a lot of restrictions from the beginning, and I know populations are also different. People, some of them like follow the rules and some of them not. And we know in Peru a lot of people don't, and I think we can now see the consequences. And they were saying in Peru their mortality is very high, even the highest around the world. And I think it's like a combination of factors between like the culture of like some people not following the rules. And I'm not saying that all of them, but I feel that some people just don't see how important, how big this is, and they don't think that that's going to affect them, and they just go and do what they want or what they like. So that could affect more people. And here I think people are like having more consciousness about like how they can affect it. And I think in New York City, I put like always New York City as an example. I've never lived an experience like I lived in New York City at that time in April, May, working in a public hospital in the Bronx. So it was really challenging, and it was a good experience. And then when we saw that the cases were getting low, we really could like feel that, and we were having a relief. So it was a complete change, and for me it was interesting to see that. I haven't had that experience in Peru because I haven't been there for a year now, so I cannot really say how it is right now. But from what I've been reading or hearing from my friends or other colleagues who work in Peru, it's also been really challenging for them in terms of PPE as well. I know like right now there's not enough PPE, or that's what I've heard. So they're having some challenges like we had in the beginning, but for them, I think it's for a longer time because it's really.
And Elizabeth, you've had a chance to kind of be on the front lines in Peru, working with MedLife and seeing what we do in mobile clinics in these communities in Lima and other places, and kind of from your experience knowing how things were going in New York and starting to see Peru come up in the news, what are some of the thoughts that were going through your mind, and in seeing the similarities or differences of the Peruvian system and the American system?
Well, I mean, I can't speak so much to the hospital system in Peru because we worked primarily out in the community. But I could see that, I mean, thinking of where we hold the mobile clinics and out in the communities in the shanty towns, as you could say, some of them don't even have running water. So I can imagine that washing your hands, hand hygiene, access, I mean, if we don't have access to adequate PPE, then they certainly don't. So I would think there's a stark difference in access to those things, and that they must have a much harder time, more challenging to stay separate, social distancing, be compliant with the regulations and the things that keep the spread from happening. So in regards to the hospital system down there, I'm not exactly sure how they're handling it. I only got to see it in bits and pieces while I was down there. So I can't really speak to that so much.
Yeah. And Nick, you're obviously very well versed in both kind of splitting your time between Peru and the United States. What were the things kind of popping out in your mind in knowing the differences and similarities in Peru and the US of when all of this was starting to hit the news and Peru was becoming this focal point? What are some of the things that you kind of seen as potentially causing that?
Yeah, it's just such a different reality, right? I mean, if any of the MedLifers are here, please correct me on the numbers that I'm going to say right now, but I think that the United States has something like 100,000 ventilators in the country. And my understanding is we had, I don't know, maybe another 50 or 100,000 like BiPAP, CPAP, things like that that could be used as ventilators. I want to say that Peru, as a country of 30 million people, has something like 500 or 1,000 ventilators at a countrywide level. Correct me if the numbers are there, but I mean, you get a sense of the scale. It's just completely different, right? One of the major issues early on in Peru was just the lack of oxygen, people running out of oxygen. That is something where there was a lot of concern in the United States about running out of ventilators, right? I mean, you have people like Elon Musk talking about creating ventilators, and the Dyson vacuum guy creating ventilators in the UK, I think. And like, there was all this, private enterprise kind of push for ventilators. And in a country like Peru, it's not even a question of ventilators. It's a question of, are you going to just run out of oxygen, right? We had a staff member that came down with COVID who's in his 60s, and immediately as he had the diagnosis, we started working on trying to acquire an oxygen concentrator, not because he was feeling short of breath, but because we knew that if he developed shortness of breath, the likelihood that going to the public health hospital and having oxygen available was so low that we had to try and get that early on, right? And you can imagine in MedLife, it's such a small community and we have some resources to do that. Most people that work in some of the informal settlements don't have that kind of ability. I think there's also, a lot of differences in Texas. There was a pretty hard pushback initially against masks. That's changed, I would say, since Texas really became a hotspot and Houston became a hotspot, and you've seen more people adopt it, although there's still a lot of misinformation. I think that while there's some misinformation in Peru, I think that it's more, the issue of compliance is more of an issue of just kind of stark needs that exist within communities. So some of the communities that we work with said things like, we're less afraid of dying from the virus. We're more afraid of starving and not being able to eat, right? And that's just something where certainly, there are communities and there are people that are facing really tough times in the United States, and people that are going to, soup kitchens and things for the first time in their lives. But the scale is just kind of incredible to see in Peru. I mean, I've been working in Latin America in different countries for the last 20 years, and I've never seen the level of outpouring of need for food like we saw in Peru when everything went down, and I've seen, and I work in a rural, pretty low income community in Texas, and nothing like what's going on in Peru. So it's difficult to understand. I mean, I think that Peru tried their best to lock down really hard, and it's so unfortunate that they ended up in this situation, because for all practical purposes, it seems like they locked down early, they locked down hard, they tried their best, but I think the limitations that a lot of the population face, if they don't work a day, they don't eat that day, and if they don't work 3 days, they don't eat for 3 days. And so in that sort of reality, it becomes a real challenge to stay at home. People can't work at home and be on a laptop like this, right? I mean, all those people are manual laborers or working in people's homes or things like that. It's not the kind of work that they can stay at home. And when they do stay at home, you're often talking about a house that's maybe 400 or 500 square feet at the most, and often packed with people, right? And so in my home, I have the luxury of every time I come home from 10 days in Texas, I can quarantine and I can stay away from my wife and my son for 5 days until I get a COVID test. If I did get COVID, there would be a way that I could try and stay away from them for 2 weeks. The reality in Pamplona and places where we work in Peru, if one member of the family gets COVID, effectively the entire family gets COVID. There's just no way to try and quarantine around that. So it's really a complicated situation. And it's really been challenging for MedLife in terms of trying to meet some of those needs.
Okay. Thank you. We're going to take a question from our YouTube listeners. Once again, I ask anyone that has questions to please drop them in the comments below or share them on our Zoom meeting, and we will answer them as we go through. Starting with Elizabeth, one of the viewers are asking, how much truth was there to the news in comparison to what you were living? Obviously, COVID has been in the news for a long time, very polarizing on kind of both sides, but can you just speak to kind of a little bit of what we were seeing in the news versus what was actually happening on the front lines?
Sure. Well, in the ICU, we saw the worst and the sickest COVID patients. So from what I was hearing in the media, when the conversation sort of shifted towards this is being overplayed, that was especially hard to hear because I was going into work and seeing patients that were on extremely high ventilator settings, on heparin drips for the hypercoagulability of COVID, and on pressors because their blood pressure was dropping and their infection on multiple antibiotics. And I'm conducting family meetings with these patients that are never going to be discharged, and their families will never be able to come in and see them. And then you hear news stories of these claims that things are being overblown and that, masks are violating people's rights and whatnot. And it was very frustrating. So I do think that there was some inflation of the truth in the media to a certain extent, maybe in some regards, but for the most part, the most frustrating thing for me was hearing the claims that it was overblown and that it's not a risk to anyone, because it might not be a risk to a healthy person, but if you acquire COVID and you're a healthy person and then you give it to someone who is elderly or has multiple comorbidities, then I'm here and I'm working with the patients that are those people who contract it from otherwise healthy people. And the end result of getting COVID as someone with multiple comorbidities is very, very sad, very sad. And me and my coworkers, had to deal with a lot emotionally in terms of seeing those patients pass away with no family members around and no family members allowed to even see them. So that was frustrating. I would say some of the media, for the most part, kind of leveled out a little bit at some point, but it had its ups and downs.
And Nick, what about you in comparison to what you were seeing on the news and seeing during surges in Texas? Was it accurate? Was it overblown? What were your thoughts?
No, I would say in general it's pretty accurate. And again, Elizabeth really hits it on the head. I mean, it's all about somebody's perspective. If you're 22 years old, the likelihood, the vast majority of 22-year-olds are going to have a cold, right? And so if you're 22 and trying to go to college and be in your senior year of college, it's going to feel overblown to you, right? You're going to say, I've known people that had it and they're fine, right? But when you're sitting in Elizabeth's shoes or my shoes or Alex's shoes, it doesn't feel overblown because we're dealing with the brunt of really, really sick infections, right? I mean, people wanted to talk about it being like the flu. I will tell you, I've been practicing medicine, including since, let's say, residency, med school, let's say a decade of being in hospitals and working in healthcare. And I don't, to be honest with you, I don't think I've ever seen a patient die from the flu. I have had patients that are very sick from the flu, but it's fairly far and few between. Like even the number of flu patients that I see in the ICU that I have to admit to the hospital is pretty far and few between. Occasionally I have to admit a flu to the hospital. And again, I don't work in the ICU at this point in my career, so Elizabeth or Alex may have different thoughts on that. COVID's different, right? I've been seeing people die from COVID already, and I've seen people dying of COVID that are 60, 50. The youngest that I've seen is 26. So it's I think in some ways it's not overblown, and people are, they just don't understand the scope of it. I mean, I think people say things like we should just go for herd immunity, right? And I don't know that people really understand the implications of that. I mean, so for example, where I work, that was a common thing, and even now some people are saying, oh, I think we're just going to have to go for herd immunity. I mean, I think we've had 8 or 10 million infections in the United States and had something like 200,000, 216,000 deaths so far, right? If there's been 10 million infections, herd immunity doesn't come until you get to about 70%. And so let's just say that that is, 300 million, just to make math easy, right? That's like 210 million. So that means we're 200 million people away from herd immunity. That means, we would have to go 20 times as many deaths as we've currently seen. So when you start doing what we do for a living, things like herd immunity don't feel like a realistic plan. It might be an unfortunate reality, but it's not a realistic plan in terms of how to attack this. So yeah, that's my feeling on that.
And Alexandra, how did your experiences contrast with what you were seeing in the news every day?
So I think I also agree, like it was pretty accurate. I know there were some documentaries or like news where the emergencies were like full of people, like they couldn't really, there was a patient, like they were sick, it died, they just like have to jump to the other patients. Sometimes they didn't even have time to just grieve or a time to think or just like to think a little bit more about what they're doing, just like act and do it quickly because the patient was dying. And also I know sometimes in the news they were saying like we have to make like decisions regarding what patients have to be in the ICU. We have to sometimes choose between, if we just only have one bed, which one of them would be the one who would have like the more benefit from going to the ICU, and the other one just to the floor with not enough resources or with experienced nurses not experienced in the ICU or managing drips. And another reality that when I was working in the ICU is that we had to put all the infusion pumps outside the rooms and with long tubings and close the door. So we would limit on the nurses as well, limit exposure to the COVID patients. Each time they have to go into the patient's room, they could just press the buttons outside the room without getting that exposure. So I think it was one of the realities, and some documentaries like in the New York Times or some like BBC, I think, with New York City hospitals, I think it was pretty accurate with everything.
Okay. Can you talk, Ale, just to expand a little bit, I think that especially, we have so many students that are in healthcare right now. I felt that too, this shift from in the United States, we when somebody is sick, we throw the entire like army of medicine at that person, right? I mean, we have nephrologists if their kidneys are hurt, we have cardiologists, we have pulmonologists, we have, I mean, when somebody is really sick, like what you guys were doing in the ICU, they get so many resources. And to go and to have the mental shift that I'm going to choose which patient is going to get those resources and which patient isn't going to get those resources, that's not something that exists in the United States, really, right? I mean, that is something that might exist in some developing countries. I think people sometimes talk about this idea of like death panels and things, right? Like some administrator deciding who's going to die and who's going to live, right? And for most of medicine, that just seems sort of hyperbolic and silly, right? But all of a sudden in COVID, it became real, right? All of a sudden, we were asked to be thinking about how we're going to make these decisions, right? And at least for me, I don't know how you guys did with it. Like, I don't have a lot of training in deciding the ethical decision of like who lives, right? I have training in like how to fight disease and how to help people. But in saying like the 35-year-old, maybe morbidly obese that has heart failure versus the 65-year-old who's really healthy, well, the 65-year-old, I mean, we don't really deal with that, right? And I wonder if you could both kind of talk a little bit about that in terms of like a mental shift of going from, you know, we give everything we can to a patient, to all of a sudden, even if you didn't have to do it, like starting to think about like, how am I going to choose, right? And how, I don't know, I think ethically and in terms of your practice, that's a big mental shift for people practicing healthcare in the United States.
Alexandra, how do you respond to that question of Nick's?
So at that time, I think my role at that time was as a resident. So the final decisions would make the attending, but sometimes we would have to just choose and like tell them exactly what we think. And sometimes they would just agree with it, but sometimes they wouldn't. So sometimes we would think like, okay, this patient, like Nick says, like we don't have that training about deciding who's gonna leave or who's not gonna like make it, or that we don't think it's gonna make it. So I personally, I don't think I'm able to decide that. And so we had to take into consideration too many things. And sometimes we couldn't even consult ethics at that time because they were very like overwhelmed with other patients as well. So that decision was on us. And sometimes just by calling the family and telling them, hey, like we have to move your family members from the ICU to the floors because we don't have a bed and there's a very sick patient coming and your family member is dying and we cannot do anything for him. That was really hard because they would like expect that we could do something for them. And I think, yeah, like it was very stressful in that sense.
Elizabeth?
Sorry.
Similar experience. We had social work and our what do you call them? Like patient reps, very, very involved in our rounds every day when we were working the ICUs, and it was purely COVID. So we did have to make decisions in terms of beds because we knew who was teed up to come in and who was sort of, you know, trending in a direction in which we knew they were never going to recover. They were going to have a trach. We knew that they couldn't go, there was no facility in which we could transfer them out to for long-term care. So you'd have to sort of shift what we would traditionally have as like okay, what are the goals of care for the family? What do they want us to do? Continue all measures to keep the patient alive, or start to nudge them in the direction of reality in that they're so sick, and by allowing them nature to take its course, then you can create opportunity for someone else to come into this bed who really, really needs it. It was really uncomfortable calling families every day. We would call the point person for each patient every day for an update. So that was a lot of time on the phone updating families, but if we knew we needed to have a bed, we'd have to sort of pick and choose how we would frame that conversation with families each day, even if it wasn't a formal, goals of care type conversation. So that was really tough emotionally, trying to, like Nick said, that's not what we were trained to do. What we were trained to do is to push forward and use everything in our power and all of our resources to make the patient better. But in this case, it was, sometimes you just had to have those conversations with families of patients who were actually still very critically ill and in other circumstances would absolutely stay in the ICU, to say, hey, we need to send your mother to a step down unit or to a regular floor because yes, they're still very sick. And I know you want to keep them in the ICU, but unfortunately we need to make a bed, So we all kind of learned how to frame it in an appropriate way, but it was still hard to say those things when you knew in your heart that patient really should have stayed in an ICU and really did need your help. Yeah.
Okay, I'm going to turn and ask each of you individually a couple questions from our viewers. We're going to start with Nick. A viewer asks that they've seen poverty in rural areas and in cities, speaking of Latin America and developing countries. And could you speak a little bit to the differences in how COVID has affected rural areas in comparison to some of the larger cities?
Yeah, I think, so I think the reality is, when you think about things like treatment for COVID, in Peru, I mean, Ale, or, correct me if you've heard differently, but I don't believe anybody's getting remdesivir. Like, I don't believe anybody's getting convalescent plasma. There was, I know, a lot of push around azithromycin, which has not shown any clinical benefit. And so we said before, there's not enough oxygen in the country. There's certainly not enough ventilators in the country. And if there are any kind of treatments, ICU, oxygen, ventilators, the vast majority of that's going to be in Lima, in the capital. And so I think what we've seen is that in some ways, really poor rural people in Peru have had it a little bit better, I would say, in the sense that they have some ability to fall back on agriculture, whereas a lot of the people in the urban informal settlements really are money-based completely. And so if they're not working a day, they're not eating a day, there's really no ability to fall back on agriculture at all. But the flip is also true, is that there's not really resources in the rural places. And so we've seen a lot of rural, poor, indigenous communities really lock down their own communities. And so, you think about, New York City, or as a country, we locked down. We've seen indigenous communities in rural Peru locking their own communities down and saying, nobody's coming in here. They're, putting trees or tires or whatever across the road and just saying, I'm sorry, like, unless you're from our community, you're not coming in. Which is probably the smartest thing that they could do, right? Like, if they can keep the infection from actually coming in, and if they can isolate, and if they can muster enough food, that's probably the best opportunity they have. But it's very complicated. I mean, despite that, the infection has gotten into rural areas. And, I think when I was in Peru, there was a story about some physicians passing away in the Amazon, that's just, and they were young. I mean, I think they were under 30. I mean, just horrific type stories of people being in just absolute desperate situations. And so it's not easy, very complicated. I would say the only potential benefit is the ability to fall back on some agriculture for families that have that. But at the same time, there's a lot of challenges with lack of resources. And if you do get sick, there's really not, even basic resources for you to pursue. So pretty challenging.
And Elizabeth, a different question for you. Are we starting to see a surge, and do we expect another round of the pandemic coming up in the fall as we get into winter?
We already, not to give away numbers of what's going on right now, but there's definitely been an uptick again. We have several in my ICU, in one of the ICUs in which I work, which is not the designated COVID ICU. So we're already kind of seeing some spillover again. And I mean, there's the back and forth about, we're seeing new hotspots, especially in Brooklyn. People are mostly compliant with masks, I think, and with social distancing in general. But since the regulations sort of loosened somewhat in the summertime, we're seeing an uptick again now that it's getting colder outside. People are staying indoors in closer quarters. So to answer the question, yes, we're seeing an uptick again. I don't know if it'll get to the point or how it was in March. Hopefully not, because that was very intense. But at least if it were to get to that point, at this point in time, we have a better idea of what works and what doesn't and what strategies to use. So that's kind of a small silver lining.
Can you elaborate a little bit on that, Biz? Like, what are you seeing that's been effective in terms of treatment or strategies, maybe not treatment?
Sure. I mean, I think everybody knows better when I say strategies also outside the hospital. So using masks, you don't go outside and see anyone without masks. Before, you used to only maybe see when people were indoors or in stores, things like that. But now, even out walking on the streets in New York City, everybody has a mask on. It's just become the new norm. So I think that will be helpful in terms of maybe making the second surge a little less invasive than back in March. But in the hospital before, in the very beginning, we were switching up the treatment plans every week. It was different. Like you mentioned about plasma was sort of a novelty. Now we're using it more. I've had several patients recently that have received convalescent plasma. Still hard to say how exactly effective it is because it's so early on. And then remdesivir, we have access to that now and know that it has shown some efficacy in helping decrease the symptoms. So I think overall, we're better prepared this time around.
Just last question, especially for the healthcare kids and my own interest, have you done any proning or ECMO for people? And if you have, can you explain kind of to people what that means? And
Sure. Proning, we had a proning team. So we would say it's based on the PF ratio, which I won't get into that, but basically if a patient on a ventilator meets a certain criteria, then they're a candidate for proning, which means that we flip them onto their stomachs for 16 hours. And often that will just help with the ventilation. So you'll see their oxygen levels start to go up, both on the blood tests and on the monitor. Sometimes we did see that was effective in a longer sense, in that their oxygen levels would remain elevated, but in some cases it went back down when we flipped them back over. But yeah, we had a proning team. So we would say, okay, this patient, we're going to prone them at 1 p.m. We'd call up the team. They'd, all come into the ICU prepared. They would do very efficiently, flip the patient. It's a whole process. It's not just as easy as flipping someone onto their stomach. They have to have proper protection of their skin and mucosa and everything. And yeah, so now we are able to do that on our own without a team. So that's another benefit. We know what the protocol is. We can do it ourselves with our own nurses. And then in terms of ECMO, that's where the patient has their blood oxygenated sort of externally when the lungs are so damaged that they're unable to oxygenate the blood. And we did have a couple patients who went on ECMO, but those in our hospital go to the CT ICU. So they go to a separate ICU. Once they're on ECMO, they're whisked away. We don't do ECMO because our nurses aren't trained in how to use the machine. So I only saw a couple of patients who went on to ECMO, but it's obviously an effective modality treatment, but it's not permanent. So yeah, that's a very terminal sort of approach in fixing the oxygenation issue.
Yeah, I think it does give you a sense of when we talk about places like Peru running out of just, oxygen that you give in nasal cannula, right? To in the United States, we effectively have machines that are external lungs, right? That we can actually pipe someone's blood outside of their body, put oxygen in it, and then bring that blood back into their body. I mean, effectively, you're on bypass, like in bypass surgery. It just gives you a sense of the scope of what we can do versus what is out there for people in places like Peru.
And next question for Alexandra from one of our guests. What is your thoughts and feelings on returning to normalcy in 2021? Do you think that's a possibility? What are your thoughts?
So I think that may be a possibility, but certainly I'm not completely sure. I know that there are some clinical trials regarding some vaccines going on. So, and they were saying probably if we have one, it may be in April, or we would see some advances in November or December of this year. But yeah, I'm seeing also a peak, even here in Nebraska, I'm seeing a peak in the hospital now. There are like about 15 patients, which is 116 beds in the hospital. compared to New York, where there were a lot of more patients with COVID. But I'm kind of concerned that it's gonna be a peak and it's gonna be as bad as when it was in New York, but probably not too bad because here there are like more open spaces. There are not the small studios, or that like in New York sometimes there are like living a lot of people in the same building, and that could contribute to the spread of COVID. And so I think that's what's going on, and I think it's still, yeah, it's gonna improve, hopefully. Who knows?
And since we're talking about 2021, and I'm going to bring this back to everyone in the group, this has gone on for much longer than a lot of us expected. We're starting to see COVID fatigue with a lot of people. A number of people want to continue back to their normal lives, and but at the same time, we're also seeing a lot more recklessness and the need to really ensure that young people are being more careful about what they're doing. How do you think we tackle this kind of COVID fatigue and ensuring that we're kind of protecting our most affected and most vulnerable? I'll start with Nick.
Tough question. I think the reality is, you look at 1918 and it was a couple of years, right, until it naturally happened. So hopefully we can go faster than that in terms of, hopefully if a vaccine comes out. I think, Elizabeth sort of mentioned it in New York that you really have to kind of adopt a new norm. And so, I'll use myself as an example, right? I would get out of a shift. I would take off my scrubs, throw them on the floor and like crawl into bed or jump in a quick shower or something, right? Like I didn't do any kind of post shift, like disinfection type stuff. And I've just gotten into the habit at this point that I have to do that. I have to kind of, kill everything that's on my scrubs and make sure that I have no virus on me. And it's the way I kind of look at it is it's sort of like brushing my teeth. Like this is just the reality of what I have to do now, and so I think to the extent that you can kind of adopt that there is a new normal, and that entails always wearing a mask and doing these things. I think the thing for people to keep in mind is that the economy doesn't open back up. You don't gain sort of your life back by not wearing a mask or by not, by kind of skimming and taking the easy path. The way that we get back is by wearing a mask, right? And so I think if, I'm sure everybody has seen the predictions now in terms of the number of people that may pass away by January or February. One, wearing a mask right now, we save a lot of lives. And two, I think it's the best shot we have as of today for people to stay in school, for businesses to stay open, for the economy to stay afloat. Really, as of today, it's kind of the only measure we have. And so I think people need to, my sense is kind of understand that you're in a new normal, that we're not just going to go back to, even when the vaccine comes out, knock on wood that it comes out and it's good, it's not as though we're going to flip a switch and everything's back to normal. The things that I've been hearing is it's going to take at least a year to get everybody vaccinated in the United States. And you can imagine a lot of the world is going to take longer than that. So we're in this for the long haul. And I think that that's what's needed from a lot of folks, is kind of understanding that there is a new normal, and that the best way to get as close as we can back to the old normal is doing all of these things, is wearing the mask and everything. Because not doing it is not going to lead to us to a normal situation. It's going to lead to new peaks, new hot zones. Things are going to have to close down. People are going to lose more jobs. It's going to get worse in that sense, I think.
Alexandra, how do we battle these misconceptions and try our best to protect the most vulnerable?
So I think like trying to protect the most vulnerable is just trying to, like, there were some examples, like trying to stay away from older people, or trying to sacrifice like certain meetings. Like I know Thanksgiving is coming, so I think people, like, they're saying like we should adopt a new normal in terms of meetings or gatherings. We have now internet that it's easier for us to communicate with other people and trying to protect the rest of them. Like here, I've seen that some of the people don't use a mask. I know in New York, most of them now in the streets, they use a mask. So I think that's probably because they experienced all these when it was at its peak in May or April. And here, it really hasn't been that bad yet. So hopefully it isn't, but if it happens, I think people will start using more masks or being more aware or of the other people and trying to protect them as well.
Thank you. Elizabeth, and your thoughts?
I think, I mean, it's hard for me to talk about this and truly empathize with the people who can't go to work, because I couldn't imagine working from home. I mean, here in New York City, apartments aren't very large, so generally speaking. So if I were to have to work from home, be at home all the time, quarantine from other people in the house, like that would be really, really difficult for me. Fortunately, I still get to go to work. I still get to get out of the house to go, because I work in a hospital. But like Nick said, I think it just needs to become the new norm. I've seen a shift here for sure in the past few months of just everybody wears a mask. I mean, even now gyms are starting to open up, certain things are starting to open up, and now they're starting to shut down again. But even in the gym, people wear a mask to work out. People wear a mask when they're running, when they're biking. I just think it'll be interesting to see how the winter goes when there can't be outdoor dining, and the certain sort of things that we've allowed to come back will have to shut down again because of cold weather. But if the general perception of COVID is that it's serious, it's real, we're going to get through this eventually, and people just comply and wear a mask, I think we're gonna get through this a lot faster than if people are constantly pushing against that. So yeah, I think just making it and normalizing it, and now it feels kind of normal. I don't leave my apartment door without a mask on, and if I go outside without a mask on, I feel like I'm missing a piece of clothing. So I think that's going to be the most effective strategy.
Okay. We're wrapping up here. We've got about 10 minutes to go, and we'll take a few more questions. But I want to turn this over. A lot of our audience is aspiring to work in the medical profession, and right now with lockdowns and everything that they have to deal with, it gets to be difficult doing kind of in-person work and shadowing. So starting with you, Elizabeth, what recommendations do you have for people studying or aspiring to get into medicine, nursing, and kind of getting higher learning at this point in time, or getting hands-on experience?
Well, getting higher learning, I mean, I have friends that I've worked with as nurses that are now in nurse practitioner school or getting their master's, and most of their classes have shifted to be online. In some ways, I think that's a benefit, because you can get your schoolwork done on your own time, around your own life schedule. So that's kind of convenient. Getting hands-on experience is difficult. I'm very grateful that I didn't have to get my clinicals done at this time. I don't really know how it's working in terms of for medical students who need to be in the hospital and get those hours in. I know at the peak they were told to not come in, but now they are starting to come in and do their clinical rotations in inpatient with patients. But definitely, I wouldn't be deterred by it from this pandemic. If anything, this, I think, should be encouraging to get into the medical field, because I've never seen a more cohesion among all the different specialties in medicine in the hospital than during those peak months of COVID and back in the spring. Everyone was working together. We felt like a team, and we were all tackling a common enemy. And that was really cool. So, I think if anything, this should be an encouraging time to get into medicine, because you really do make a difference, and you'll always have a job. No medical jobs really, at least inpatient, were shut down as a result of the pandemic. So it's another plus.
Alexandra, same question to you, advice for aspiring healthcare professionals who aren't able to get in-person opportunities at this time.
Yeah, and I completely agree with Elizabeth. Like, this would be an opportunity to encourage them to go into the medical field. And I know sometimes we have like certain resources online, like the New England Journal of Medicine for, like, we even have free resources, like there are some clinical simulations that they can do online, and even watching videos if they wanna do like end up doing procedures, they have to watch in order to then do it. So if they wanna do intubations or central lines or anything, there's always videos explaining step by step, and they can watch a lot of times. And then when they're able to go to the hospital or into a clinical setting, they can just do it because they already saw them like several times online, which doesn't require their presence in order to learn that. So I think it's an opportunity that it's beneficial for now.
Great, thank you. And Nick, what advice do you have for aspiring healthcare professionals?
I think both Elizabeth and Ali have really said it. It's the clinical aspect right now is pretty challenging, you know, unless you're kind of needed to be in a clinical setting, you may find it challenging. Having said that, I think that there haven't been a lot of times that I've been in healthcare that have been so, I don't know if just sort of provocative in terms of pushing issues into kind of the mainstream, right? And I think that I would, for people that are interested in healthcare, you know, a lot of folks that are interested are worried about getting into med school, getting into nurse practitioner school, kind of getting into and getting those clinical skills. I think something that, you know, I'm 40 years old and I've been attending for a few years, and you start being put in positions of leadership, right? Where people ask you questions about, you know, policy and things. And I think if I was in school and I couldn't be doing clinical stuff, I'd really think about some of those other things. You know, how does the way that we run healthcare with private insurance, Medicare, Medicaid, influence things like a pandemic, right? How can you make a healthcare system better? Naturally, you know, we don't spend a lot of time looking at you know, the way that Korea runs healthcare, or the UK or Australia. And all of a sudden, we're hearing a lot of that in the news. You know, this is how many infections New Zealand's had, or this or that. And so I think there's a natural time to learn about that stuff and kind of learn about the different approaches to healthcare and the policy. And there's so much out there right now that is really interesting in terms of learning that kind of stuff. And I think even though at this point you know, you want to kind of do that clinical thing, you want to be at the bedside. Understanding those larger issues is going to be part of your job as you kind of move into the career. So,
and Alexandra, how do you feel that healthcare and the industry as a whole needs to evolve now that we've kind of been through a pandemic, something to the scale that you know, we haven't really seen in 100 years, and going through this? What are some of the critical changes that need to happen in the industry?
Sorry, can you repeat that question? I didn't understand very well the industry. And
so in healthcare, what are some of the ways you feel it needs to evolve as a result of going through the pandemic? What changes do you see that are required moving forward?
Well, okay. So I think in terms, for example, of PPE, we know that was a problem in the beginning. So I think that they should be more like industry, like organization or companies that produces these more. So I think I can think about that specifically. Yeah.
Okay. Yeah, PPE has been such a wake-up call for all of us, even as we were watching, and all of you had to go into this. Elizabeth, any thoughts on how things need to evolve going forward?
Let's see. Well, during the pandemic itself, it was a bit refreshing in the sense that the focus, at least on the unit, among the staff and the nursing staff especially, usually it's very much about metrics. It's about how many of, you know, central line infections, how many UTIs, how long has the Foley catheter been in place? You know, they're very focused on the numbers and reimbursement for the hospital, and reprimanding the nurses and also the medical staff for things that are more about a financial gain rather than for the benefit of the patient. And that shifted away from that during COVID, because we were just focused on getting these patients better. Like, it sort of, all of a sudden it came clear to everybody, management, medical staff, all ancillary staff, that we just want to get these patients out of the ICU well enough to go to the floor and get them home, and like have that be a victory and count our numbers as positives and not negatives. Now it's starting to shift back to focusing once again on how many central lines do we have? You got to take them out, even though the patient is on, multiple medications and drips and vasopressors at the same time, but you have to take it out because they might be at risk for an infection, as opposed to focusing on what actually does the patient need. That might be a little bit complicated, but during that time, it sort of shifted us back to the good old basics of just taking care of the patient, which was really nice. And I think going forward, I wish that it would move back to that. But again, management and whatnot is very much focused on financial gains from hospital systems and medical systems in general.
And Nick, your thoughts on evolving going forward?
Yeah, I think Elizabeth, both Ali and Elizabeth bring up excellent points. Without question, you don't send soldiers into a war without the right gear, right? And the idea that you'd fight a pandemic without the right materials, gear, PPE is crazy. And I think we need to look at that and how we deal with this and not sort of be caught flat-footed in the future. I think Viz is right too. A lot of healthcare, there's just so much money in it. There's a lot of focus on not losing money, on making enough money. And, there's been a drive over recent years to not call patients, but to call them customers. And a lot of us in healthcare struggle with that, right? The customer is always right. A patient isn't always right, right? If you want your hamburger done how you want it at McDonald's, that's what you pay for. For someone that comes in and wants morphine or Dilaudid or fentanyl in the hospital, this isn't McDonald's. You don't get to choose your opiate of choice. And so I think there's a lot there that we need to think about in terms of how we organize healthcare, and really what are the outcomes that we're shooting for. Are they clinical outcomes? Are they patient-focused outcomes? Or are they kind of bottom of the line financial outcomes? And I think tied to that, we really need to think about what public health means. And so I think that in the United States in particular, we sort of struggle with this. We think about things like heart disease often as compliance of a patient. So this patient smoked a lot. They ate out at McDonald's. They were obese. They didn't work out, and that's why they've had a heart attack. Sort of implying that they've kind of led to this outcome on their own. In COVID, all of a sudden that goes away, right? It's a global pandemic, and can you really blame, a frontline worker for getting this and now they're intubated? And so, I think we need to look at the safety nets that we have in a country like the United States. How do we make sure that families can still eat when they lose their jobs? How do we make sure that teachers are going to be protected in a pandemic and our kids can still get an education? How are we going to make sure that people don't go into so much financial debt that they lose their homes because they were intubated for 65 days in the ICU and they didn't have health insurance, right? I think we need to think about kind of the mechanism that we fund these things, and are we getting the outcomes we want, right? I mean, I can't remember who said every system is perfectly designed to get the outcomes that you get. And I think we're seeing that, right? A lot of the outcomes that we get are financial in terms of what people are focused on. And I think we need to reshift our focus in healthcare to people and patient outcomes and think about that.
All right. Well, I think we're getting to the end of this. I'd like to thank everyone for being here and sharing your time with us. I'd also just kind of on behalf of all of our audience, thank you for really putting yourselves in harm's way during a really uncertain time and being on the front lines in COVID. Our hats are off to you, and would like to personally thank you for that. Also, as we kind of wrap up, Nick, I'd like to just kind of make a note of our upcoming campaign with Moving Mountains in addressing food insecurity. And could you just share a little bit of what is the current situation and availability of resources like food in the communities MedLife is working in, and how people can help?
Yeah, so I don't know that it's improved a lot. We are seeing kind of more organization and more NGOs helping communities. We're scaling, so we started feeding a couple hundred people a day. We are into the thousands now, and we are shooting for a goal of 5,000 a day is kind of where we're trying to get. Not an easy goal, both financially and just operationally. And so we need all the help that we can get. I think that, you know, in sort of a closing statement from me, what I'd really encourage everybody is, you know, 2020 has been a rough year from a lot of different perspectives, right? I mean, social inequalities and racial inequalities and healthcare. And I think that you wouldn't be wrong in feeling that the world is falling apart a little bit. But I think that from people on the front line will tell you that there's a lot of camaraderie. There's a lot of great people doing great work and working really hard every day to take care of patients and to do the right thing. And even as students, it feels like it's a long ways away, but what you do makes a difference, right? And I think in MedLife, especially with campaigns like Moving Mountains, reaching out to grandma, you know, your cousin, your uncle, your aunt, and saying, hey, would you be willing to give $5 or $10 to this campaign? It may feel like you're not doing a lot, but the reality is we all use the skills that we have to make a difference when we can, right? And the work that you do is important. You're going to do great things. We all need to remember that there are positive things happening every single day, despite the onslaught of all the negative news, right? And you can do great things even in this kind of environment.
Oh, fantastic. And I once again want to thank all of you for being here. As healthcare professionals, it's never easy to schedule a time when you're working on shifts where everyone can be available at the same time, but we really appreciate it. We appreciate the service to MedLife and to your communities, and just want to thank you for being here today. So Elizabeth, Alexandra, Nick, thanks for being with us. And we will look to respond to any of the questions that didn't get answered in this show. I would like to thank our MedLife communities and chapters for tuning in on this, one of many roundtables. I think it went fantastic, and we'll be excited about trying to do another one in the very near future. But for now, we're signing off. Once again, thank you, everyone. Have a wonderful night. And Elizabeth, Alexandra, Nick, thanks for being with us today.
Thank you, everybody. It was fun.
All right. Bye, guys.